The views and opinions expressed by the guest panelists and/or presenters do not reflect the views or opinions of the Delta Research and Educational Foundation, DREF Research Matters for All of Us, the NIH All of Us Research Program, or any of these organizations' affiliates. Tonight's presentation was pulled together by our amazing volunteers, Alicia Bethel, Janine Adderley Bryant, and Mother Margaret Williams. And we are going to turn it over to Alicia so that she can introduce us to tonight's featured guests.
Thank you, Lakeisha, for the information and update on All of Us research. Next, Janine Bryant will introduce us to our distinguished guests. Janine.
Well, thank you so much. We are happy and grateful to have our three distinguished guests. First, we have Dr. Mariela Otagosa-Gogans, who is an associate professor of medicine at the University of Miami Miller School of Medicine and the medical director of the Kidney Pancreas Transplant Program at the Miami Transplant Institute in Miami, Florida. She completed her medical education at Quintallo Herrera University in Lima, Peru, and her medical training at Henry Ford Hospital in Detroit, Michigan, and Georgetown University in DC. Dr. Ortigoza-Goggins has been a practicing transplant neurologist since 1993. She has been involved in medical education and held many administrative positions, including medical director of the Live Kidney Donor Program and of the Kidney Pancreas Transplant Program. Her focus has been clinical research within the field of transplantation and has a special interest in the long-term follow-up of former African-American kidney donors, which has led to several publications. She is currently the principal investigator from the University of Miami in the NIH-sponsored study, APOL1 genotypes and long-term kidney transplant outcomes, the Apollo study. She is part of the dissemination committee within Apollo, which focuses on education of the community on kidney disease and the importance of research participation. Our next guest is Dr. Damian Jackson. Damian Jackson is the Director of Business Development and Community Outreach at Miami Transplant Institute, a unique affiliation between Jackson Health System and the University of Miami Health System, UHealth. Dr. Jackson also serves as the adjunct professor at the Florida International University College of Nursing and Health Sciences. And he's a lecturer in the Patient Advocacy Program at the University of Miami, Dr. Jackson received his doctorate in healthcare education from Nova Southeastern University and is a member of the American Society of Transplantation, AST, the American College of Healthcare Executives, the American Association of Kidney Patients, and the Organ Procurement and Transplant Network. He frequently provides education on a variety of topics related to public health, patient advocacy, healthcare disparities, kidney disease, and the importance of organ donation. Our last guest is Dr. Emmanuel P. Nwang. Dr. Emmanuel P. Nwang is a graduate of the Florida A&M University with a doctorate in pharmacy and completed an ambulatory care residency with emphasis on HIV and AIDS therapy. He is a licensed pharmacist consultant and completed certificate training in pharmacogenomics. He is a native of Miami, Florida, and of Nigerian descent. He comes from a long line of healthcare workers in his family, from physicians, pharmacists, and registered nurses. Dr. Nwang specializes in metabolic disorders and chronic disease consultation and ambulatory care management. He developed WCRX Health to broaden his scope of clinical practice for patients with metabolic disorders, mentally and physically handicapped, and the chronically ill, particularly in CKD, chronic kidney disease disorders. His motto is "Prevention is the secret to wellness," and strives to keep the motto as part of his traditions, along with doing no harm to his clients. So we thank our three guests and we welcome them tonight.
Thank you, Janine, for those introductions. Our first panelist will present an overview of kidney disease. Please join me in welcoming Dr. Mariela Ortigosa Goggins. Dr. Goggins, you may proceed.
Can you see my screen?
Yes.
Yep, Phil, thank you very much for the nice presentation. It is an honor for me to present before this prestigious organization, all what we've heard the last 10, 15 minutes of this amazing organization on what you do. Prevention and treatment of kidney disease is the topic, and we'll move on. So facts about kidney disease, and a lot was presented at the Kahoo game, and most of you did well. I'm just trying to now reconcile and maybe give more information. So yes, indeed, 1 in 3 American adults are at risk for kidney disease, and yes, indeed, 37 million American adults have kidney disease, and most do not know it. But what you may not know is there is 100,000 people on the wait list to receive a kidney transplant. The list is long. Community education is essential to our to prevent. So early detection, why is community education important? Because early detection is really the only thing that could prevent the progression of kidney disease to kidney failure. Not knowing that you have this silent disease could be catastrophic to learn at the end. Heart disease is the primary cause of death for all people with chronic kidney disease. People that have kidney disease, luckily there is dialysis. Dialysis will save patients with kidney disease. They don't die from kidney disease, they die from heart disease. So the heart and the kidney are quite linked. So as we mentioned before, what are the main causes of kidney disease? 2/3 of the causes of kidney disease in the United States are diabetes and hypertension. Diabetes, of course, is when the blood sugar remains elevated. It's a silent disease because if it's unmanaged, it will cause damage to the kidneys, it's damage to the heart, blood vessels, nerves, and eyes. It's devastating and it's silent. High blood pressure or hypertension is when the pressure is increased against the walls of the blood vessels. And again, it's a silent disease that if uncontrolled will cause heart attacks, heart failure, strokes, and kidney disease. So those are the 2 most common that we should be aware of. But there are other conditions that affect the kidney disease. The number 3 leading cause is what we call glomerulonephritis. It's a tough name to pronounce, but it's just inflammation of the kidneys for unclear reasons. Is the number 3 cause. There are other inherited diseases. For instance, what you see on the right side, the pictures, that is called polycystic kidney disease. It's an inherited disorder that causes the kidneys to form very large cysts in both kidneys that will damage and leads to end-stage kidney disease or end-stage kidney failure. There are other conditions that causes also kidney disease. One of we have heard already earlier is this called lupus nephritis, which affects the African American community and is an autoimmune disease. So all this leads to kidney failure, but starts as early kidney disease. What are the risk factors? How could we prevent? Can we prevent chronic kidney disease? Anyone can get chronic kidney disease at any age, but there's some people that are more likely to develop than others. So we want to identify this. Who are the people that are at risk to develop this chronic kidney disease? For instance, if you have diabetes, you're at risk of kidney disease. You have high blood pressure. Family history is quite important. If there are in your family there is history of kidney failure, you have to be aware and diagnose and prevent early. If you belong to a population group that high rate of diabetes and hypertension, we've talked now in the last 30 minutes, African Americans are at higher risk to develop diabetes, hypertension, therefore kidney disease. What are the causes of hypertension or high blood pressure? The exact causes we do not know. But there are some things that may play a role in developing or that could actually be prevented. For instance, smoking increases hypertension. Being overweight is a big factor of hypertension. Lack of physical activity, sedentary. Too much salt in the diet is not good. Too much alcohol, more than 1 or 2 drinks every day, that could lead to hypertension. Older age, as we age, we could develop hypertension. Family history, as I mentioned, race is important. As we mentioned, African Americans have much more higher rate, more often and more severe hypertension than non-African Americans. So what are the symptoms of kidney disease? It's a silent disease. Most people don't know. Not until it's very advanced that you're going to develop symptoms. That's what is so important to prevent. Don't wait for the symptoms. Tiredness, fatigue, lack of energy, trouble concentrating, poor appetite, trouble sleeping, swollen feet, puffiness around your eyes, the dry, itchy skin. These are all very late consequences of kidney disease. We don't want to wait until that happens. Need to urinate more often. That is, people that may think it's the opposite, but you stop making urine. No, actually you urinate more, especially at night. You need to wake up 3, 4, 5 times because the kidney disease itself. So what do we do? How can we prevent? The prevention is by diagnosis. The only way that you could start the preventing measure is by being diagnosed. Your yearly physical exam is quite important. You go see your doctor, they're going to check for a urine test, a very simple urine test, looking for protein that could anticipate kidney disease. And in the blood test, we're checking the creatinine level. Creatinine is a waste product that when it's elevated, it's a marker of kidney failure. And we use that to calculate what we call glomerular filtration rate, or GFR. This is just a marker that measures your level of kidney function. So there are different stages of kidney failure. There are the early stages, stage 1, 2, maybe 3, and there are the latest stages, 3, 4, and 5. So as this GFR changes, you are advancing in your kidney disease. So how could we prevent? The heart and the kidney go hand in hand. What is good for your kidneys is good for your heart. There are many things that we could do once you've been diagnosed with kidney disease to prevent progression. At this level, at this stage, this year, 2022, we do not have a magic pill that we could take that will resolve the kidney disease or the kidney failure. So it's what can we prevent progression is what we're going to be focused on. So what is good for the heart is good for the kidney. So regular physical activity helps both losing weight, maintaining a good weight balance. Eat less fat. Fat food is not good. If you have high blood pressure, you have elevated blood sugar, your fats are elevated, you have to keep it under control. Fortunately or fortunately, we do have medications for both. We have medications for hypertension, diabetes, and elevated fats in the blood. You have to seek advice to that. Stop smoking will help your heart, will help your kidneys. It's not just the heart. Stress is a big problem for the heart, for the kidneys. So learn to cope with your stress, find ways that you can eliminate it. Again, what is good for your heart is good for your kidneys. Now, what else can we do to prevent progression of kidney disease? There are some common habits that may harm your kidneys, and we do not know it. For instance, overusing painkillers, what we call the NSAIDs, or non-steroidal anti-inflammatory agents, the commonly drugs like ibuprofen, for instance. Those are really bad for the kidneys. If you have kidney disease, do not use those. And you will learn that by seeing your doctor. There are other pain medications that you could use, but you have to avoid these NSAIDs that we call. Abusing the salt shaker, eat less salt. Change your habits, change your dietary habits that use herbs and other spices to flavor food instead of salt. Processed foods is a big one. Not many people, or there's lack of education, how bad processed foods are. Processed foods are high in salt and high in phosphorus. Both damage the kidney, or particularly phosphorus makes the progression of kidney disease worse. Not drinking enough water. Kidneys like water. We need to drink water. There is sometimes people think because I have kidney disease, I should not be drinking enough water. No, it's the opposite. We need to drink water. Too much meat, particularly red meat. Plant-based protein is the preferred protein for patients with chronic kidney disease instead of meat. So change your diet from red meat to plant-based protein meat. For instance, soy, beans, legumes, grains, nuts, seeds, oils. Instead of vegetable oils, change it to olive oil or so on, and quinoa as well. So diet is very important in preventing progression of kidney disease. Unfortunately, when things happen, either you were not diagnosed or despite knowing, you progress. You progress from chronic kidney disease, now you have end-stage kidney disease. So what are your choices? You either get a kidney transplant or go on dialysis. So I'm not going to talk about much about the difference of dialysis, but as you probably know, dialysis is you go to a center, you get needles stuck on your arm, and to draw the blood, and the blood is run through the filter that will clear all the waste products because your kidneys are not working. Now, instead of that, you can go and get a kidney transplant. Kidney transplant requires surgery. Your old diseased kidneys are not removed, they stay where they are, and the surgeon will come and implant a kidney on the anterior part of your body in the lower part, and that will avoid having to go on dialysis. You as a community, as a person, somebody that has chronic kidney disease and is progressing, now you're in stage 3, now they're 4, as soon as your kidney function is under 20%, you should get on the kidney transplant list. The kidney transplant list is very long. You don't need dialysis until your kidney function is under 10%, but you could get on the list when your kidney function is under 20% to start accruing time since the list is so long. Okay, now there are other factors that could also participate in the progression of kidney disease besides the one I just mentioned. Social determinants of health is very important. It's linked to poor health, and in particular, kidney disease. Kidney disease is one of the areas of the social determinants are important when there is lack of good food, good nutrition, good transportation, good medical insurance. That all is part of the social determinants. Not going to spend much on this. We're all aware of the factors. However, I want to spend a little more time about your genes. How about your genes? Not the genes that you want to wear, not the genes that you wear, not the genes that you are trying to fit in as you lose weight, but your genes as your genetic makeup. Is anything in your genetic makeup that makes African American more prone to kidney disease, more prone to hypertension, and so on? So as we go to a dialysis unit here on the right side, you see this lady, middle-aged, not diabetic, non-obese, that had hypertension, did everything the doctor told her to do, took her medications. Despite all that, she reached end-stage renal disease. Now she's on dialysis, waiting for a kidney transplant. So we go look at the left side. We see the incidence. This green line is the incidence of African Americans with end-stage kidney disease, 3-4 times higher incidence than Caucasian Americans. So why is this? Why does African Americans have higher incidence of chronic kidney disease? Do we know? Is there anything in there that we now have, the scientists have discovered? Is the answer your genes? Is the genetic makeup of African American has something to do with the development of kidney disease or hypertension? And the answer is yes. Scientists now have discovered a gene called ApoL1. ApoL1 when there are variations or mutations in this gene, it appears to cause higher incidence of kidney disease. So the discovery of ApoL1 some few years ago really has changed the paradigm on chronic kidney disease. This ApoL1, which is normally appearing, if there are variants, if there are mutations, and the mutations are called G1 or G2, these mutations happen so people or human can prevent a parasite disease called trypanosoma that causes an illness in Africa and West Africa. So human nature is to mutate to prevent this. disease. This disease causes African sleeping sickness. It's very prevalent in Africa and West Africa. The parasite is called trypanosoma and is carried by this fly called tsetse fly, and it's devastating disease in Africa. So human nature was to, okay, let's mutate, and over for a few hundred years, they mutate. So now these people from Africa are protected from this African sleeping sickness if they have a variation on this APOL1 gene called G1 or G2. However, we're looking here on the right side. If you carry those both variants, the G1 and G2, the discovery is that now we do have higher incidence of kidney disease. Up to 20% may have kidney disease. Whereas if you have no genetic variants or only one of the genetic variants, you don't have risk of kidney disease, but you may carry it to their children, so they become carriers. These two variants is not that uncommon. 13% of all African Americans will have these two APOL1 variations on the gene. That represents about 5 million people in the United States alone. And those are the people that are at risk to develop kidney disease based on the research that we have done. 39% of African Americans have just one of the variants, which is fine. They won't have kidney disease. They will be protected from African sleep sickness if they are in Africa, but they become carriers. They could become carriers to their offsprings to develop to carry now the two variants and carry kidney disease. Interesting enough is these risk variants, these variations, these mutations in APOL1 are absent, do not exist in Caucasian, Europeans, Hispanics, or Asians. Is only limited to people of African descent. So right now, what is the take-home message for you? Do your yearly physical. Make sure your doctor checks your urine and blood for looking for kidney disease. If you have hypertension or diabetes, control it. Change your your lifestyle to a healthy one, your healthy diet. Awareness, monitor your kidney function. Have your doctor monitor your kidney function. If you're getting close to the magic 20%, get on the transplant list. Be a registered donor for organ donation, participate in research. Now, as far as the APOL1, at this point, it's important that awareness, the education, the knowing there is a possible factor linked to kidney disease by having a mutation in the gene so-called APOL1. There's research going on this as to how does this variance cause kidney disease. We don't know. We only know that there is an association. We don't know how it causes it. And if we know how it causes it, we can develop therapeutics to prevent the progression of kidney disease based on these variants of APOL1. And is also looking into the consequences in kidney transplantation on patients or kidneys that carry these APOL1 genetic variants. At this point, I'm going to stop, and I thank you for your attention.
Wow, thank you, Dr. Goggins, for sharing with us a wealth of information. Some is new to us, and thank you so much. So the 3 takeaways that you provided is that we must have our yearly physical exams, which is so important. We have to have our blood work done. We have to follow up with our physicians to know what the blood work says. We have to have our urine checked, ask questions about our urine, monitor our kidney function. As African Americans, we really just have to take our medication. If you have hypertension, don't take the garlic pills, take your medication. If you're diabetic, take the metformin. That will lessen your chances of developing kidney disease. Thank you, Dr. Goggins.
Before we move on, we do have one question in the chat. And Shepard asks, is genetic testing recommended to see if we are APOL1? And it jumped up, I apologize.
Yep, I understand. That is a very, very good question. This is research, ongoing research. At this point, this test is available. It's actually available commercially. Most insurance will not pay for it, but you could know. So the purpose of knowing, do I carry this APOL1 variant? Is it important or not? At this point, the community is not recommending it. because there's not much we could do. You have the mutation, what are you going to do? If you have hypertension, you have to treat it. You have to do the best you can to take your medication. Same for diabetes. We're not recommending. The only group that we may recommend is, and this is part of research, is if you are going to be a live kidney donor. I want to donate a kidney to my mom. I'm African American. There's family history of hypertension. Do I carry that gene? So if I donate my kidney, I may end up in kidney failure. That's the only time at this point in time that we might recommend getting tested for it.
Thank you for that. For the remaining questions in the chat, we're going to address them later on in the presentation. But right now, I'm going to go to Dr. N. Dr. N. Tell us about WCRX and how does that relates to kidney disease?
Okay, thank you for having me. Well, WCRX was organic. It started actually during my residency, where we would work with the health department, actually in HIV/AIDS, and we would travel to the inner cities, to the churches, mainly African American churches and things of that nature. And we would do blood pressure screenings, glucose testing, basic things. And we noticed that it was just alarming how many people would just say to us, oh, that's how my pressure is. That's how it is in our family. And it was like, no, this is not how it works. And it was just amazing. And from that becoming something where I was doing it in a residency, from volunteering and going to churches to having a bunch of churches invite me, and then it became a trend, and then it became a business at the end. And I just could not believe, because at the time I was doing it as a resident, and then when I left, I started working in a local hospital there, but I would constantly get called back to come and do those volunteer things at different organizations. And I just could not believe, I just assumed somebody's doing it. I mean, I just graduated, what do you want from me? And that was kind of the attitude I had, but I could not believe every time I went to every single location, in particular in the African-American community, it was just so common. And then of course, me going to Miami, talking to some of my Hispanic friends, and I just started noticing the trend. And I was like, my God, we think this is normal. And I just could not believe it. So that's how WCRX Health, in a sense, it grew organically. It wasn't something that I was, had this great idea one day it's going to happen. I just could not believe nobody was addressing it in this fashion. So that's how it started, from there.
Thank you. And thank you, Dr. N. for the wonderful work that you've begun in our community. My next question is for Dr. Jackson. As the Director of Business Development and Community Outreach at the Miami Transplant Institute, or MTI, what are the common barriers that you've seen facing the minority community as it relates to kidney disease and or kidney transplant?
Hey, Alicia, I'm not sure why my question was longer than everybody else's, but I'll allow it. So for me, I've got a unique perspective. So of course, you just explain my whole title. The card goes front and back, capture all of it. But I'm blessed to also serve in this capacity as an educator, as one who does community outreach in the neighborhoods I grew up in, right? And so Dr. Emmanuel touched on it. These, this is a safe space. So I feel like I can be a little bit loose with this group. These are my people, right? So I see patients when they come in for evaluation. My first role in healthcare was a community educator, a patient educator, specifically for stage renal patients. And so Dr. Goggins gave a really comprehensive list. And if I had to narrow it down, I think you touched on it as well. One thing is the importance of yearly physicals, having a primary care physician. In our communities, and again, I feel safe saying this in this company, we're not doing a good job of seeing our primary care physician. The time when we are going to seek medical attention is when our headache is so bad it feels like our head is going to explode, or our legs and our feet are so swollen that we can't put on our shoes anymore. And then, okay, well, let me go to the ED and see what's going on. The emergency room, the emergency department is not a primary care physician. It is not a substitute for yearly physicals. These are things that are supposed to be, or these are environments that are supposed to use in the event of an emergency. And these issues and these symptoms wouldn't have been an emergency had we found out about them a year ago or 2 years ago. And so that is, I think, the biggest challenge within our community. And when I say our community, I'm including African Americans and Hispanic, because, for our transplant area, that's the community we serve. So with a disease like CKD, you've got phases, right? So you've got phase 1, phase 2, phase 3, phase 4. And fine, you come to the emergency room, we diagnose you with CKD4, and now we're putting measures in place and treatment in place to try and slow the progression from stage 4 to stage 5. We should have started slowing that progression at stage 1, right? Because if it takes you longer to go from stage 1 to stage 2, and then stage 2 to stage 3, you are dealing with a much longer timeline and not starting when you're already in a very critical and vulnerable position. And so I know if any of my CEOs or chief administrators were on here, they probably slap me on the wrist for sounding like I'm trying to cut down on the number of kidney referrals, but I am. I really want our communities to not have to need transplants and not to have to go on dialysis. I really want that to be the message, as opposed to using dialysis as, okay, here's our safety net. Okay, transplant, here's my parachute. I don't want us to get there. And just to put some numbers behind what I'm telling you, we do approximately, over the last couple of years, even including COVID years, we do over 700 transplants a year. 500 of those are kidney transplants. 500. Mind you, we transplant hearts, we transplant lungs, we transplant livers, 500 kidneys for a disease that, again, with some of these measures in place, for annual checkups, watching our lifestyle choices, our food choices, our nutrition choices, exercise choices, we could significantly cut down. So if I have to leave this group with one message and you only remember me for one thing, it's that we really need to emphasize, not only for ourselves, because obviously we have an interest because we're on this call, but for our loved ones, our neighbors, our family members, and our community at large, that is the key piece, kind of curtailing the progression of kidney disease.
Thank you, Dr. Jackson, for the wealth of information that you've given us tonight. The number 500 kidney transplants a year, that's very alarming. So we need to do better at monitoring our kidney function and going to the doctor like you suggested. The next question is back to Dr. Goggins. You mentioned diabetes and hypertension were the main causes of kidney disease, but why are people of color specifically at a greater risk? Can you expound on that a little? And is there any research that can validate that?
Right, there is, it's not a simple answer. There's many factors. There's not one factor that causes the African American community have hypertension or diabetes. It's environmental, it's socioeconomic, it's genetic traits, it's, it runs in the family for a reason, so it has to be in your genes. But there's a lot of factors, and socioeconomic is important. Diet, nutrition, eating the wrong food, it just runs again and again in the same community. There's no one answer to that question. I think it's important for research to know, and one of the research that we're interested in is identifying APOL1 as a genetic trait that could be the cause. Of course, that's where our research is, but it's not all genetics, as it's not all environmental, as it's not all socioeconomic. It's all of the above. So it's all the factors. The bottom line, like Dr. Jackson just said, is get your yearly physical. If you are diagnosed, prevention is the key. There's no even a magic pill to reverse kidney disease. It's all prevention, and it's all slowing down the progression of kidney disease. That's pretty much at this stage in life what we could do.
Thank you for that. Having our kidney function monitored is so important. And for those who are not funded, there are places in the community that can assist us. There are several clinics. Even Jackson can assist you. You can get a Jackson card. You can have your labs drawn so that you can have your kidneys monitored before they progressed to stage 4 or 5 and you need a kidney transplant. So Dr. Goggins, do you have a presentation for us on a research study you're involved in?
Yes, I would like to share my screen. You see my slide?
Yes, thank you.
Right. So yes, there is an ongoing research that Miami is participating. It's called Apollo, which is ApoL1. This is the gene that I've been mentioned on my first part of the talk, is the effect of ApoL1 on long-term kidney transplant outcomes. So as I said earlier, some variations on this ApoL1 gene, the G1 and G2 that I mentioned, contributed as higher, maybe even higher than 30% of the end-stage kidney disease in African Americans. So this excess risk on kidney disease in African Americans does not happen in European Americans or other populations because they don't have these ApoL1 genetic variants, and could also explain poorer outcomes in patients with lupus nephritis. In African Americans, they do worse than non-African Americans. And in particular for this study is the shorter survival in kidneys transplanted from African-American deceased donors. So the study is now looking at those kidneys from donors that go into the recipients that they don't do as well. Is there a link to these ApoL1 genetic studies? So Apollo is an NIH-sponsored study. It's a national study that is trying to assess the effects of these variants, of these variations in this gene called ApoL1 from African-American donors. They donate the kidneys, they go into the recipients, and we're going to look at the outcomes of these recipients of these kidneys. We're also looking at the health of the African-American live kidney donors. They may have these variants and they already donated their kidney. We want to make sure it's safe for for African-Americans, live kidney donors, that it's safe for them to donate the kidneys. So Apollo is a big study. It's a national study. It involves all 260 transplant programs in the United States and Puerto Rico. It's divided among 13 clinical centers. Miami is one of the clinical centers, and we're trying to grab every single kidney transplant done in the country. But what is very interesting about this Apollo organizational chart is this corner, the Community Advisor Council. This is one of the first studies that the NIH is taking community participants to help us design and help us with the study. So the Community Advisor Council is composed of all African Americans from the community. They are not doctors, they are not nurses, they are not scientists, they are just community people that are either transplant recipients or live kidney donors, or they themselves may have kidney disease, or their family members of kidney disease. We want their participations because we feel that this is a study of African Americans, and we don't want just non-African American scientists and doctors doing the study. We want the participation of community leaders that could help us actually design so we can get more and more acceptance from this to the study. These are the people, these are the participants in this community advisory, the community advisory participants. They come to the NIH, they sit down with us, and we talk about the study and how could we better develop it in a way that is accepted by the recipients. So for instance, they help us a lot in developing these brochures. There's infographics, how to better explain participants what Apollo is, what this genetic condition is, what is these genes and that could affect your kidneys. And they come with these nice graphics, nice pictures that explains the situation. For instance, this is my favorite one. It explains here, you could have the G0, which is no increased risk of kidney disease. If you don't have the variant, you don't have kidney disease. You have a G1 or G2, you do not have increased risk of kidney disease. We know now this is to prevent this parasite disease, African sleeping sickness, but you do not have, but you could carry it in to your children. Or you have the two, when you have these two genes, the double hit, 4 out of these 5 people may get kidney disease. This is where the 20% come. So this is a nice slide that the Community Advisory Council has helped us develop so we can present this to the participants. And this explains what Apollo is, what the mission of Apollo is. In summary, as you get kidney donors, you give it to the recipients, and we want to know if this genetic variance has any effect on the outcomes of these kidney recipients. So what does Apollo need? What Apollo asks for the participants? This is from deceased organ donors, so patients that are donating their organs at the end of their life that are of our recent African ancestry. So there are African Americans, Africans, Hispanic Blacks, Afro-Caribbeans. They call it self-report as recent African ancestry. We ask the family or the next of kin, they have to authorize research. They have to authorize research so we can collect the blood sample and take this APOL1, this blood sample, and do the genotyping for APOL1 to determine if they are carrying or not these genetic variants. But we do need the authorization from the next of kin. And this is something that the Community Advisory Council was very emphatic about it. We don't want to do this research without actually telling the family or the next of kin that we're doing research. We want to be open. We want to be transparent. So what are the challenges? We actually started the study, the Apollo, the long national study. And by the time we thought we should be 100% recruited and 100% participants out of the number that we picked, we were only at 40%. So we started looking, why are we not able to recruit? And these are things that came up part of the study. There's certainly lower organ donation rates among African Americans. If we compare the organ donation rates, signing up to be an organ donor between African Americans is much lower than Caucasians, than Hispanics, than Asians. It's much lower. Now, research authorization, I just mentioned, we have to get the next of kin to allow research for us to enroll a patient in Apollo. We found that the patients were donating their organs, the family were agreeing to donate the organs, but they said, no, I don't want research. Take my organs, take the kidney of my loved one, but do not authorize research. That's something that we found that was very difficult to understand. Maybe not difficult from your end, but for us as scientists, were difficult to understand why no to research. Another one was the recipients declining participation. They just didn't want to participate in research. And what we saw also, which is a known fact, is the live kidney donation from African Americans, the life is much lower than other ethnic groups. So why is the next of kin not agreeing to participate? As an unexpected finding, and we try to, this is what we're doing, this community engagement, this is what trying to increase participation and organizations like yours to increase research, say yes to research, it is important. So just so you know, if you are a registered donor, for instance, in the state of Florida, we call that first person authorization, you register at your DMV, and when you register as a donor, you're also registering for research and education, and is irrevocable by the family next of kin. However, there's some states that the law said, well, the donor signed their card, but the family still needs to agree, not only to donate, but also to research, and that's when the problem starts to happen. So within Apollo project, we follow, it was very variable. We are anywhere as low as 10% and as high as 50% of the donors. This is African-American donors. They are given the greatest gift of life. Your relative is passing away, you're donating the organs, but you're saying no to research, up to 50% of those cases. That was very difficult to comprehend. So, initiatives like these ones, this is back in the 90s, it started as a local organization and became a national outreach program. Share your decision, share your life, you register to be an organ donor. This is a very powerful initiative, in this case by influential person in the community. If Michael Jordan says it, we should do it, but everybody can be an influential person in the community. You don't need to be a Michael Jordan to, talk to your community and be influential. We are all influential in our own family, in our community, to increase be registered to be a donor. Share your decision. Tell your family, yes, I am registered to be an organ donor if the situation happens. So it is important for African Americans to participate in kidney research. We've heard this in the first part of this event. African Americans, there's many unrecognized types that are overrepresented when it comes to kidney disease and dialysis. Is this genetics or not genetics? Is it important to also come up with medications that are geared towards African Americans? As they said in the presentation, Dr. Collins, most of the research, most of the trials are done in Caucasians. African American participation is very low. We don't know if it's going to work or not. So we have to increase the participation of African Americans in research, and it's up to us, it's up to communities, up to organizations like yours to spread the word. And so just to close now, how can you help us? How can you help Apollo? How can you help the scientific community? Talking post to your community. Increase your donor registration. Register to be a donor. Tell your family, your community, your neighbors to be a registered. Share your decision. Tell your family, yes, in case something happens, I want to be a donor. I register to be a donor. Register for research. I want to allow research as well. And then the awareness of APOL1. This is something you're gonna hear more and more in the coming years. This is a generic variance. It's nothing that you as a community did wrong. It's in your genetic makeup. You just need to be aware that exists and is linked to kidney disease or possible link to kidney disease. Overall, participate in research, increase live kidney donation. There's a lot of need for kidney donors. And if you're healthy and you could do it, why not help your relatives or your loved ones? And that's all I have.
Thank you, Dr. Goggins. Do we have any organ donors as participants? Show us by sending us a heart. Send me a heart. I'm a donor.
Very good.
Thank you, Dr. Goggins. So you really place emphasis on the fact that African Americans are least likely to donate or participate as donors, but we have the greater need. We have the greatest needs, and we often linger on the kidney transplant list much longer because it's difficult for us to find a match. So it's so important for us to get involved and participate in the medical community and in research. You also place emphasis on the fact that most research in the past has been done on white males. Well, we're not really white males. We have a different body types and we have different genetics. So this is why we're encouraging people of color to participate in research so that as new treatments are coming out, as new meds are being discovered, they have our DNA in the bunch so that we can have better outcomes. I'm going to move this question to Dr. Jackson. Why do you think so many people of color are hesitant about participating as organ donors? Because this is something that we have to figure out.
Okay, again, another tough question Alicia just sent to me. So somebody's getting a strongly worded email after this whole presentation is wrapped up. I see what's happening here. So let me answer that in two parts, right? So let's talk about organ donation and then living donation. So one of the things that I think is impacting regular organ donation rates among our community are myths and misconceptions, right? So a lot of people, and I've heard it, and some of you on this call have heard this as well. Well, if I sign up as an organ donor, God forbid I'm in a car accident, they're gonna take their time with me in the emergency room. They're not gonna give me the best level of care because they want my organs, right? Which again, I see a lot of people laughing, but that is a common popular misconception within our minority communities, that as an organ donor, they're not going to try all life-saving techniques and treatments for you because they want to harvest your heart and your lungs and all these other things, which couldn't be further from the truth. So our role, not only within this organization, but within our outreach, our other circles, is to educate community as to how that process works. There's no lesser medical attention or lesser treatment of care. As a matter of fact, the organ process or the organ donation or procurement process after the fact and the actual medical attention you receive in, say, an emergency room or that type of setting are two separate things that are happening at two separate vortexes, right? So that's one of the things. And so those myths and misconceptions, drive organ donation in the community. The other thing that we've noticed, and specifically this happened just very recently, we were doing an initiative with Miami-Dade County Public School, where we were getting into high schools where students are just becoming drivers, getting their restricted driver's license and their driver's licenses. And we were watching the process as they go through it, right? So they do the test and they do the eye test and all this other stuff. And when they're filling out the information, they're kind of breezing past organ donation, right? They don't even notice it, right? They're so excited just to get their license, be able to drive. Like, that's not something that's very prevalent or predominant on the application, so they don't notice it sometimes. So we've done some initiatives at the high school level to encourage organ donation at an earlier age. And you asked the question, and I hate to be morbid with this group, but right now I see 56 participants on this call. That's 112 potential kidneys. Just throwing that out there, right? And when we all go to the upper room, those kidneys will be of no use to us, right? So why not leave them for the patients who will ultimately need transplants, down the road in the future, right? Leave that as your legacy, right? So that's one piece on the organ donation side. Specifically as it pertains to living donation, I think we collectively do a very poor job, because I think we send a mixed message, right? So here's the message. Number one, African Americans are higher risk for kidney disease. Second message, hey, please sign up to be a living donor. Well, if I'm an African American and I'm at higher risk for kidney disease, I'm not giving you one of my kidneys that I might need in 3 or 4 years, right? So we have to really bifurcate that message to make sure it makes sense, because any logical person is going to say, wait a minute, I'm going to give you this kidney that I need. No, that's not going to work for me, right? And so part of the benefit of the study that Dr. Goggins spoke to is that with Apollo, you can find out if you are at greater risk or genetically predisposed to kidney disease, right? And so if you had to make the decision for a brother, for a loved one, do I want to give them a kidney? You take the test and you realize you are at no greater risk whether or not you give them that kidney or not. The likelihood of you doing it is going to be very high, as opposed to if you don't know. And so we really need to attack organ donation. And again, collectively with this group, I'm asking each and every one of you on this group as well, we really need to kind of dispel the myths and misconceptions, number one, on the organ donation side, and speak to the benefits and the legacy there. And then on the living donation side, encourage people to participate in these types of research studies. Last point before I let you go, we have started doing living donor nephrectomies at Miami Transplant Institute. This is a robotic technique where, let's say, for example, two people come in, one is going to be a living donor and one is going to be a recipient. Using these robotic features and this way of procuring the organ, our hospitalization rates for donors have gone down dramatically. And you guys can go on our website, you can kind of check it out on Instagram and some of those social media sites. We've had instances this year when somebody came in to donate a kidney on a Thursday and were discharged home on a Friday with minor pain medication, no risk of infection, very short hospital stays. Our ladies who are considering donation, very minimal scarring, right? Because that's important too. That's a consideration for people who are considering donation. But this is another way that we can kind of influence people to consider being living donors, because it's not really a huge sacrifice physically, financially, or a burden in terms of recovery time. That's going to increase the likelihood of living donation in our community as well. So sorry for the long-winded answer, but I think I needed to kind of explain that in two parts. So my apologies. And no more questions from you, Alicia. I'm done for the night. Thank you.
Thank you so much, Dr. Jackson. Dr. N. Wong, and then we're going to go to the chat with Janine. Dr. N. Wong, Dr. Goggins mentioned the role of NSAIDs in harming kidneys. Are there less detrimental remedies to headaches or pain that you would recommend? Or are there something that you're doing in your clinic?
Well, yes, we always tell the folks that have issues with kidneys, definitely they can't take any of the NSAIDs, the ibuprofens and aspirins and things of that nature. We hopefully hope that they don't have any issues with their liver because of Tylenol, but that's like the drug of choice to utilize for pain. If Tylenol, for whatever reason, is an issue, tramadol, which is now considered a narcotic and controlled, but those are some of the alternatives that patients can use I really wanted to highlight something and piggyback, and this is no way defending, because we as African Americans and people, minorities, have to, of course, take accountability in what we do. But I did want to mention, when Dr. Goggins was mentioning with genetics and what Dr. Jackson mentioned, I kind of get into the community and I see things in a social, not even social economic, because I noticed that depending on, it didn't matter what financial arena the person was in the minority community, it seemed to be the same type of issue. They can be rich, they can be poor, and they still have the same disease issue. And one thing that I've noticed is that our history plays a huge role. And I know I'm getting a bit off topic because I just mentioned the medications, but I did want to point that out. Our history plays a very huge role in this disease process. And the reason why I say that is because I've been doing this from volunteering in the churches to doing this since I graduated in 2006. So it's been quite a while. And the devastation of things that have happened to our people in our community make us pretty much have these misconceptions, from not taking the vaccine to the things that happened with the Tuskegee experiments and everything under the sun. So you can imagine, I'm from Miami and I'm speaking to someone from the South, and their families are from Tennessee or deep South, and they tell you straight stories where their family members were butchered and all these types of devastating things. So you can imagine me, they just say, oh, you're one of them. You just got your degree. Now they don't believe you. So it's going to take a culture change in our communities, also in diet, because even when I've mentioned it in churches, some of those church mothers want to beat me down when I'm making comments about certain foods that during the holidays that they should change. So there's a lot of little things community-wise that I do believe that we can really speak of, because what has always annoyed me when I would work in the ERs is they want to know these things when they're in the ER, and it's by that time pretty much too late. So I just wanted to mention that because it's really important for us to recognize that.
Thank you, Dr. Nwang.
Yes, thank you. We do have a question from the chat. Ms. Martin wanted to know, are there any natural alternatives for high blood pressure? So I guess with regards to the medication, do you recommend any natural alternatives? Well, I'm not going to ask Dr. Jackson to answer because he was clear that we weren't asking him any more questions. So if any one of you want to take it, we'd appreciate it.
And of course, there's natural. We don't always just jump on giving medications, They say, no, go to the doctor, I come up with 3 different prescriptions. No, that's not how we process things. We want to do the natural thing. We want to do escalate. The first thing you do, you change your diet. If you are overweight, you lose weight. If you are a salt shaker eater, you put the salt in your French fries, already salty, then you have to change those habits. Once you change your habits, you change your diet, you exercise. Sometimes that's all enough. That's all you need. You don't need medications all the time. You change your lifestyles, you change your habits, your blood pressure improves, you don't need medications. Unfortunately, if you're not able to make all those healthy changes, and we can't wait 2-3 years for you to lose the weight or to stop eating salt, then we have to proceed with medications. That's what they're here for. And they are lifesavers. I don't know if Dr. Ingwan, you have any suggestions as well?
Exactly what you said is just like I mentioned, the church mothers get upset when I'll tell them, well, why don't you take some of the pork out of the greens and less salt? And they look at you like, who are you talking to? So it's culture and it's those things. But if they don't want to do that, medication is the next thing. So exactly what Doc said, I really don't,
Well, thank you. And I think the consensus is preventive care. With that said, we have another question. Is there something in particular that we should ask during our annual medical checkup to ensure that the kidney function is included? So is there a particular test or specific test that we should ask for to make sure that, the proper things are run so that we can find out if there is something going wrong?
So when you go to your physical, your insurance will cover, and if you don't have insurance, there's other ways to cover it, but the doctor will know that besides just doing your physical, checking your blood pressure, is checking blood work. You have to ask, is my kidney going to be checking that blood work? You don't get by with this insurance that want to go cheap on you and not doing this creatinine test or kidney test. Kidney test should be part of your yearly physical. And same for the urine. Sometimes the urine is not included. Urine is very important and it's very cheap for insurance to do the urine test, and the prevention and the consequences of an abnormal urine test can lead to many things. So you ask for blood tests, checking your creatinine, or you just say, I want my kidneys to be checked, and urine, checking for protein, make sure I don't have those two elements. That's very important.
Okay, thank you so much. We did have a question, and we do have someone, because everybody didn't heart. So we have some people who hearted in the chat that are organ donors. And one of our organ donors wanted to know, is there an age limitation on being an organ donor? And even though Dr. Jackson said he wasn't going to answer, he did. So I'm going to read his response as well as refer to the slide. But no, there isn't a cutoff point. So you can donate at any time. And I think we also saw there is no age limit on organ donation. 33% of organ donors are over 50. And I think we did see in the slide that we had a lady that was 94 years old, I believe. That was able to,
yeah, that's the world record. The world record. There's really, right. So for deceased donors, there should not be any limits. Is how healthy you are, from babies to way adult, elderly. For live donor is a different situation, but for deceased, there should not be any limits. It's how healthy you are.
Okay, thank you.
Thank you. So I have an important question that someone texted me. How does salt impact the kidneys? Because people of color, we like our food to taste good. And for that reason, we use salt, and we all guilty. What can we use as a substitute? Hispanics too. What can we use as a substitute to salt so that our food would taste good, and so that Dr. N. Wong would not get the side eye from the mothers in the church? Any of the panelists.
Do you want to answer that, Dr. Engwin? Hello?
Yes, I can answer. Well, what I've mentioned at least sometimes is things that they're not happy to hear, but I'll tell them try sea salt. You know, it's an alternative, and they always give me this look, and I'm like, I'm telling you, after a while, your palate will get used to it. I've been doing it for years. We have history of high blood pressure in our family, so I've mentioned that as an alternative. You would really be surprised how, as you reduce certain salt intake or look at the foods that you're eating, people think I'm weird when I'm walking in Walmart or places like that, because now they force you to have nutrition facts. Turn the thing over, take a look at it, and that should help you gauge on how much sodium intake, because of our body being a large, it's already a large percentage of our body having sodium in it. We're just adding to the fact. So sea salt is definitely one of the good ones. Sea salt with iodine. Doc, definitely jump in on anything that I might have missed. But that's one of the things that we've mentioned, because sometimes when you tell them no salt, they look at you like, whatever, I'm going to use salt. So then I'll say, okay, try sea salt. I'll tell them, there's different spices that you can use that have no sodium, or the food that you already have has sodium, and just, slow down as much as you can.
Yeah, there are other, like the salt substitutes that have potassium instead of sodium, which is much better for you. But at the end of the day, it's just changing your taste buds. If you are used to salt, it's going to take time for your taste buds to change from the high salt to the lower salt and the salt substitutes. Salt substitutes, herbs, other things that could spice up and flavor your food in a different ways. Talking to a nutritionist, I'm sure there's a lot of information in the internet, but talking to a nutritionist would also help. They are very, talented in how to, rearrange your diet and have very good ideas of how to cook in a way that is tasty and healthy as well.
Dr. Irwan, is it the same to use pink Himalayan salt? Or is that just as bad as regular salt?
Really, I always tell folks to look at the back of the nutrition facts. Sodium is literally a huge portion of what our body is made up of, and it's really important. But when we do too much of it, it's a problem. So I always tell folks, the fancy names, the Himalayan and all these things, honestly, that's just to make sales. Salt is salt. It's going to do the same thing when it gets in the body. The human body will take in those different electrolytes, and they bring them to where they're supposed to go. So when you do too much, it starts to cause issues. So I tell everyone when I give them advice, just turn it over, look at the salt intake or look at the makeup of it. Just like Doc said, the utilizing potassium instead of the sodium is definitely a direction to go. But the reason I mentioned sea salt is because it's a natural substance. It spreads out all the different electrolytes in your body in a sense, and sodium is not the major portion of it. When you get salt, it's all sodium. Like there's no, it's just straight sodium, which increases the blood pressure, brings the fluid into the body, increases the pressure, and then the damage starts to go from there. So the fancy names, it may work, sometimes they are really good. And they're very expensive, but if you can't afford them or you just want to utilize something that's just common, definitely look at the back of the products. I always tell everyone, look at the back of the products, look at the ingredients. That's going to tell you by law what it is in there. And you usually, if you ask your physicians your gauge, sometimes you'll say, Doc, how much should I do? How much shouldn't I do? They usually will give you an idea from that point. And I'm telling you, the taste bud things like Doc mentioned, you'll be so surprised with time. You'll say, wow, I stopped doing this and now I started doing this. And when I tried what I used to do, I almost passed out because it felt so salty to me or it was so sugary. It's really the truth. Your body literally it tries to adjust itself to what you do to it. So utilizing the back of the packages and looking at that will definitely help. But Himalayan salts I've heard are good. I always mention sea salt. I usually will tell folks iodine, because sometimes people use sea salt without it, and the doctor will say your levels are going down, especially for females and things of that nature. So doing that will definitely help.
Okay.
Well,
Thank you for that. We have one more question and then we're going to wrap up. So a question that was sent to me that was also placed in the chat is, once you have been placed on a short-term transplant list, is it likely that you may die while waiting for a transplant?
So
Dr.
it's a good question. So I assume you're referring to a kidney transplant. So
Yes.
when you go on the list, you go for various organs. Fortunately, for kidney failure, we have the option of dialysis. We cannot live without kidneys. We have to have something. So the science community developed this dialysis 50, 60 years ago. So dialysis replaces the kidney. It doesn't happen with the heart, the lungs, the liver. That's a different story. So people, while waiting for those organs, may die while waiting for those organs because there's no alternative. For kidney, we do have dialysis that keeps you alive while you're waiting for a kidney. But there's still, unfortunately, people that die waiting for a kidney that never came while they're on dialysis. More so for complications from other nature, particularly the heart. When you're on dialysis, it's bad a combination to be on dialysis, have kidney failure, and have heart disease. So you could have a heart attack. You're waiting for a kidney and you get a heart attack. So yes, it could happen, but for the most part, that's not always the case compared to other organs. But the bottom line is, if you're in kidney failure or you're on dialysis and you need to get on the list early on when your kidney function is less than 20%, talk to your doctor, send me to the transplant program. I need to go on the list. And second, look for a live donor. The list is long. Overall, in the United States, 100,000 people waiting for a kidney transplant, only for kidney transplant. You have to get a live donor. Talk to your friends, talk to your relative. Doesn't have to be necessarily related, has to be healthy. If you're healthy, you can donate a kidney. That's the bottom line. talk to people. People are unaware. People are shy. They don't want to ask, "Will you leave me a kidney?" But through community education and awareness that you're on dialysis, you need a kidney, people may come up. There's a lot of altruistic people there. We see that in and out. That's the most beautiful part of my job, is when you see these altruistic donors that come and say, "I don't know this person, but I'm gonna donate a kidney because I feel like that's my role in life," and that's a beautiful thing to see. But overall, that's the idea. You're on the list, get on the list early, look for donors, because that's the only way you're gonna get off dialysis. Otherwise, you're waiting 2-3 years, sometimes even longer. You are in Miami, you're lucky, you're only waiting 2 to 3 years. Try to go to New York or California, you're waiting 7-10 years for a kidney. That is unbelievable that things could happen like that. When you can get a live donor, find your donor and move on.
Thank you, Dr. Goggins.
Can I
So
add
as we-
something, Alicia?
Yes, you can, Dr. Jackson.
Thank you so much. So to add to Dr. Goggins' point, so just want to be clear, the importance of getting on that kidney transplant list early, right? As soon as you get under 20% kidney function, extremely important. On our other organs, for example, like liver, it's not based on the amount of time you've been on the waiting list. It's based on how sick you are, how poorly your liver is performing.
Yes.
So somebody who's extremely sick will get a liver quicker than somebody else who might have been on the list longer, but who is not as acutely ill. Kidney, it is primarily driven by the amount of time you've been on the list. So you have to get on that list as early as possible. And then one other thing to Dr. Goggins' point, and I'll be quiet, is one of the other methods that we've been seeing specifically when it comes to living donation, and it's a little bit easier than having a conversation with someone face to face, social media, right? Now we have individuals who go on social media and say, "Hey, listen, I'm suffering from stage 5, CKD5, I'm in need of a kidney transplant," and things like that. You'd be amazed at not only family and friends who will step in to donate, but to Dr. Goggins' point, philanthropic donors who will read the story and just feel led to do this kind act for another human being. So greater love has no man than this, right? So that is another outreach or in-reach method that you can use if having the actual conversation is a little bit more difficult. So that's all I wanted to add. Thank you.
Thank you, Dr. Jackson, for that ad. So as we wrap up, the last question for each of the panelists, what is the biggest takeaway that you would want us to remember, Dr. Inline? 1 to 2 minutes.
Well, the biggest takeaway that I can say is our motto has been for years since I got out of college is prevention. We always have a motto where we say prevention is the secret to wellness. My dad would always say prevention is better than cure. That's a common African proverb that some of them will say prevention is better than cure. You'll always hear them say that, and it really is the truth. Awareness is so important in our communities. That's what got me into it. Again, I was doing HIV/AIDS, but some of the drugs caused kidney issues, and the patients would have HIV/AIDS, diabetes, high blood pressure, and they didn't die from HIV/AIDS. They died from the kidney problem. So prevention is always the key to these things, especially for kidneys in particular, because it's actually a reversible thing that can, in certain instances, you can reverse kidney failure. People sometimes start out with acute. So our lifestyle, our culture change is really, really important in our community. So that's really the best response that I know I can give. Once you've gotten to the next level is when you're going to meet people like Dr. Goggins and Dr. Jackson. We try to stop, no offense, but we try to stop it from happening because it doesn't have to happen. That's the part that has me so annoyed is you have time. It's just that our lifestyle and, like I said, I was not joking. When I made comments in a church, they looked at me like I was crazy when I told them the things that they should slow down on, and they smiled, but they kind of gave me a look like, whatever, I'm still going to do it. So prevention is really important. And that's pretty much the most that I can say about that.
Thank you, Dr. Inline. Dr. Goggins, what would be the biggest takeaway in 1 to 2 minutes that you want to share with us tonight?
Yes, I think this session has been very, very important, very educational, a lot of information for people, lay community that may or may not be aware of things. I guess after listening to Dr. Ingwen, what he just said, is all true. The one word I would like for you to use is take control of your own life. Take control. Don't wait for the government to do it for you. Don't wait for, I'm waiting for an appointment, they haven't called me. Or, oh, I called and they haven't returned my call. Take control. You are only who you are by you taking control. Go for your yearly physicals, go for your blood work, call your doctor, say, why didn't you do a kidney test? I need a kidney test. Take control of your own health, take control of your own life. That's the only thing. Don't wait for other people, other organizations to do it. You are in your own control. And educate yourself and be aware of what options you have.
Thank you. Dr. Jackson, can you bring us home?
Sure. I'm gonna go a different direction, right? So you look at what we've been through in the last 2 years, right? So COVID came out of nowhere, took us all by surprise, and look at the tenacity, the enthusiasm, the engagement we had to go get vaccinated, stand in line to get tested. Kidney disease has been around a lot longer than COVID. It has disproportionately impacted the African American community more than COVID. And it will be around far after we find measures to manage COVID. So as my students would say, I want to age myself right now. Let's keep that same energy, okay? Keep that same energy and tenacity we used to fight COVID and get vaccinated and get tested and all that other stuff, and put that same energy into yearly physicals, annual checkups, and preventing chronic kidney disease, subsequently kidney failure. So that's it.
Thank you to each of our panelists. Thank you for the wealth of information that you've given us. We know now that we need to focus on our kidneys. We need to follow up with our physicians, have our blood work, have our urine checked. And Dr. Nwan, would I tell the mothers in the church, instead of using ham shanks, use smoked turkey. So when you take something away, Dr. Nwan, you got to give them something to replace it and encourage gradual steps. Now I'm going to introduce again Miami Citywide Coordinator, Lakeisha Monroe, for closing remarks. Lakeisha.
Thank you so much. That was such a great presentation. I learned so much. One of my key takeaways has been every time we have one of these sessions, I hear you have to talk to your doctor. There are certain things to ask for. And that has been so helpful in improving the way that I approach my relationship with my doctor, because before he would say, well, what are you here for today? My annual checkup. I didn't know what else to say. And I just figured that he would do whatever he needed to do to make sure that I was okay at the end of that checkup. And if I didn't hear anything back from him, I knew everything was all good. But I never thought to ask to make sure, are you checking my kidney functions? Or can we do a urine test? Or ask any of those additional things that I've learned from the doctors that have presented before us month after month. And I feel that when it's time for me to go for my next session, I'll be able to have a better relationship and a better conversation with my doctor and ask for additional tests or even the questions to make sure that he is covering all the bases. We're so trusting, right? Tonight, again, we want to thank the partners that came out, especially our community partners, the Zeta Gamma Omega chapter of Alpha Kappa Alpha Sorority Incorporated. I'd like to give a special shout out to Sandra L. Jackson. I lovingly call her my DD because she was my division director in Toastmasters. And she was the one who pointed me in the direction for me to go. She connected me to Ms. Kim McCrae, and she facilitated tonight's partnership with getting Dr. Inwang on. And of course, I have to give honor to Dr. Martha Johnson Rutledge. She is the president of the Gamma Zeta Omega chapter, and we give you honor. And we thank you all 300 plus of you, for being a part of this community and serving us for over 82 years. Thank you very much. Of course, we thank our health professionals tonight, Dr. Inwang, Dr. Jackson, Dr. Goggins. I learned so much about that Apollo study. I'm going to do some more research. We are going to make sure that we put this on YouTube and share this out. We have over 370 members now on our email list. Thanks to tonight's event, we've grown tremendously, and we will make sure that we share this information with them. If there's anything that you would like for me to share when we send out our newsletter, please feel free to email me and I will follow up with you. And with that, we are going to let you have your evening. It's time for me to get the littles in the bed. You all have a great evening. Thank you for being with us.